Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 575 of our pharmacotherapy series, which majors in geriatric drug use. The first case involves patient TMC from parts 573 and 574 of this pharmacotherapy series. And the first question reads: what is an optimal therapeutic plan for management of TMC's hyperlipidemia? TMC is a 73-year-old female with history of diabetes mellitus, elevated cholesterol and blood pressure, conferring a 10-year atherosclerotic cardiovascular disease risk greater than 7.5%. TMC's treatment plan should begin with lifestyle and dietary modifications. Based on her high atherosclerotic cardiovascular disease risk level and concomitant diabetes mellitus, a high-intensity statin should be started to lower LDL by at least 50%. However, the relative benefits of statin therapy should be weighed against the potential risk of adverse reactions. Liver transaminases should be monitored on a regular basis. Although rare, elderly patients, particularly the frail elderly with low body mass, may be at increased risk for muscle-related side effects. The hydrophilic statins pravastatin, rosuvastatin, and pitavastatin are not metabolized significantly by the cytochrome P450 system and may present fewer side effects and lower potential of drug interactions. Both atorvastatin and rosuvastatin may be given at any time of day, owing to their longer half-lives. Additionally, atorvastatin is less affected by renal impairment and may be preferred in TMC. Clinical guidance for the care of adults over age 74 with hyperlipidemia is limited by lack of clinical trial data. Current guidelines recommend for the continuation of currently tolerated statins as patients age. If new statin initiation is required after age 74, a careful assessment of risk versus benefit is warranted, and guidelines recommend for consideration of moderate-intensity statins in patients who would otherwise be candidates for high-intensity therapy. Medical conditions, such as presence of high cardiovascular risk or vascular dementia, functional status, and overall prognosis, may be helpful determinants in these cases. At this time, there are insufficient data for guidelines to support combination therapy. If combination therapy is indicated, ezetimibe can be added to further reduce the levels of LDL and reduce cardiovascular outcomes without escalating the dose and potential side effects of a statin, as shown in the IMPROVE-IT trial. Combination of a statin with niacin is less preferred. Results from the AIM-HI trial found no added clinical benefit despite improvements in lipid profile and a possible increase in stroke risk and adverse drug events. Additionally, intolerable side effects of flushing and risk for myopathy and hyperglycemia may limit use. The addition of fibrates to statins has become controversial in patients with diabetes, as shown recently in the ACCORD lipid trial. The addition of fenofibrate to simvastatin in patients with diabetes did not reduce the rate of fatal coronary heart disease events, non-fatal myocardial infarction, or non-fatal stroke compared with those who received only simvastatin. Finally, because alcohol can increase triglycerides as much as 50%, abstinence is strongly recommended. The next question reads, what other interventions should be implemented to optimize management of TMC's coronary artery disease? Any strategy to optimize TMC's coronary artery disease management should take into consideration the patient's functional status, comorbidities, and risks versus benefits. TMC is still experiencing anginal pain on her current regimen, possibly caused by more advanced disease or inability to adhere to the 4 times daily regimen of isosorbate dinitrate. She should be evaluated for coronary vessel disease and appropriate antiplatelet therapy initiated if necessary. A once-daily long-acting nitrate preparation, isosorbate mononitrate abbreviated as ISMN, may be better suited for her, with sublingual nitroglycerin available as needed. TMC should be maintained on first-line coronary artery disease therapy of aspirin and beta blockers because aspirin is indicated for myocardial infarction prevention and beta blockers may also be beneficial for heart failure. To prevent further endothelial injury from the atherosclerosis that leads to plaque rupture, statins are indicated as described previously. Angiotensin-converting enzyme inhibitors have been shown to reduce mortality and to provide secondary prevention in coronary artery disease, particularly among those 65 years or older. These agents should be part of the regimen because angiotensin-converting enzyme inhibitors also have benefits for TMC's heart failure and hypertension, as well as diabetic nephropathy. Although calcium channel blockers are indicated in coronary artery disease, they have not been proven beneficial for heart failure. Therefore, verapamil may be held at this time whereas the other agents are being optimized. TMC has uncontrolled hypertension. How should this be managed in light of her advanced age? Despite her advancing age, TMC's blood pressure is well above the goal of less than 140 systolic 90 diastolic for diabetic patients as set forth by the American Diabetes Association, abbreviated as ADA, and the 2014 Evidence-Based Guideline for the Management of High Blood Pressure in Adults, report from the panel members appointed to the 8th Joint National Committee, abbreviated as JNC8. Hypertension is present in more than 2/3 of individuals older than 65 years of age. Despite having the highest prevalence of hypertension, only a small percentage of this population is controlled or adequately treated for their blood pressure. In patients greater than 60 years of age without diabetes mellitus or chronic kidney disease, a blood pressure goal of less than 150 systolic 90 diastolic is appropriate. The HYVET study has shown that a mean reduction of blood pressure from a baseline of 173 systolic 91 diastolic by 15/6 mm of mercury in patients 80 years or older resulted in a 30% reduction in stroke, a 39% reduction in rate of death from stroke, a 23% reduction in the rate of death from cardiovascular causes, and a 64% reduction in the rate of heart failure. Although adequate dosing and combination therapy may be essential in achieving blood pressure control in the elderly population, close monitoring is also necessary to avoid systolic blood pressure, abbreviated as SBP, less than 120 mm of mercury based on the recent findings from the Accord BP trial. Intensive target of systolic blood pressure less than 120 mm of mercury did not reduce fatal and non-fatal major cardiovascular events, but increased the incidence of adverse effects. Serious side effects of aggressive BP lowering include hypotension, bradycardia, hyperkalemia, and elevated serum creatinine, and these effects must be diligently monitored. For TMC, it is recommended that adequate doses of furosemide and an angiotensin-converting enzyme inhibitor or angiotensin II receptor blocker with close monitoring be the main therapeutic approach for her hypertension. Extended or controlled-release formulations of metoprolol or carvedilol should be considered as it has for heart failure management. Though beneficial for coronary artery disease and hypertension, verapamil in sustained-release formulation should not be used based on TMC's unstable heart failure. TMC reports that she frequently feels lightheaded and shaky after she takes the glyburide. She admits to not taking glyburide regularly because it also causes rapid heartbeats. So my next question to you reads: what is an optimal therapeutic plan for the management of TMC's diabetes mellitus? Comprehensive diabetes education needs to be initiated, stressing the importance of weight loss, self-monitoring of blood glucose, alcohol abstinence, and medication adherence. A 5% to 10% weight loss will improve TMC's glucose control and cardiovascular status. TMC's alcohol consumption and self-reported erratic meal schedule may be contributing to the hypoglycemia, in addition to the glyburide, as well as to the worsening of her hypertension and heart failure. The daily recommended allowance of alcohol is no more than 2 drinks, that is 24 ounces of beer, 10 ounces of wine, or 3 ounces of 80-proof liquor, for men and no more than 1 drink for women. Glyburide is also a long-acting sulfonylurea and is associated with severe hypoglycemia more commonly than other sulfonylureas, because of its active metabolites and highly renal elimination. In general, the elderly are more susceptible, even at low doses, to hypoglycemia and may have difficulty recognizing the symptoms of hypoglycemia. Among the second-generation sulfonylureas, G-lipotide or glimepiride is preferred in renal impairment. Meglitinides, such as repaglinade or natglinade, may be preferred over the sulfonylureas in the elderly population because they do not require dose adjustment in renal compromise and also allow for a more flexible meal pattern. These agents, however, require multiple daily dosing and may still contribute to hypoglycemic risk. Any new diabetes medication should be initiated in low doses and gradually titrated upward to avoid hypoglycemic episodes and to achieve glycemic goals in accordance with ADA guidelines. The current treatment algorithm for diabetes states that metformin with lifestyle modification is the initial management approach. Per FDA labeling, metformin is contraindicated in TMC because of a serum creatinine greater than 1.4 mg per deciliter. However, the The American Diabetes Association and European Association for the Study of Diabetes reports that metformin seems safe unless eGFR falls to less than 30 ml per minute. As such, consideration of dosage reductions when renal function begins to decline below 45 ml per minute may be appropriate. When metformin is contraindicated or inadequate, the effective and affordable sulfonylureas or pioglitazone may be added. Caution for risks of side effects such as hypoglycemia should be exercised. Pioglitazone should be avoided in TMC owing to her history of heart failure. Injections such as GLP-1 analogs are often reserved unless a patient's HbA1c remains above 8% while adhering to an appropriately titrated oral combination regimen. Basal insulin can be added if A1c is significantly elevated at baseline, or if patients fail to achieve glycemic goals. More expensive and less effective A1c lowering alternatives may include dipeptide L-peptidase 4, abbreviated as DPP4, inhibitors and sodium glucose cotransport 2, abbreviated as SGLT2, inhibitors. Dipeptide L-peptidase 4 inhibitors do not promote hypoglycemia and may be considered early on during the disease state. Their dosages, however, need to be adjusted if the creatinine clearance is less than 50 ml per minute. In general, the priority of diabetes management in the elderly population should be on reduction of cardiovascular risks with strict control of blood pressure and lipids in addition to avoidance of hypoglycemic events. HbA1c goals in older adults should generally be 7.5% to 8%. In the presence of few comorbidities and good functional status, an HbA1c goal between 7% and 7.5% may be appropriate if it can be safely achieved. Higher HbA1c targets may be appropriate for some elderly patients who are functionally impaired, cognitively impaired, have complex multimorbidity, end-stage illness, or are prone to hypoglycemia or falls. It is recommended that glyburide and pioglitazone be discontinued, and either G-lipotide or repaglinate in combination with sitagliptin or basal insulin such as glargine be initiated for TMC's diabetes mellitus. Finally, comprehensive screening of diabetic complications should be done routinely to decrease morbidity and mortality. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 576.